Here we go. Hello, everyone. Welcome to the June CARES Third Thursday webinar. This month only on the second Thursday of June because of the Juneteenth holiday next week. My name is Alvin Cotton. I'm the database coordinator for the Georgia Council, but more important, I'm a person in long-term recovery. What that means to me is it's been 23 years since I felt the need to take a drink to deal with my anxiety, my loneliness, my depression, my isolation, or my legal problems. I work for recovery to make sure that every time someone seeks recovery, I want one of us to be across the table from them because we are the best help. We have a great presentation today. Our presenter is Shannon Rapier, and she is going to be talking about how trauma impacts the brain, the connection between trauma and substance use. It will be a comprehensive overview of how trauma impacts brain function, emotional regulation, and behavior, leading to an increased risk of substance use disorders. Participants will gain insight into the types of trauma, its physiological and psychological effects, and the cycle of self-medication. It will emphasize the importance of trauma-informed care principles in treatment settings and offer practical tools and strategies to address both trauma and addiction effectively. Right, this will be an interactive presentation, so please make sure that you're available when we need your engagement and participation. Little housekeeping stuff. We please keep your microphone on mute if you're not speaking. I'll go ahead and mute everyone in just a minute. And as host, we will mute people as needed. Everyone who remains until the end of the webinar will receive 1.5 CEUs. You'll get that from me, Alvin Cotton, probably to go out early next week. Anyone who shows up more than 15 minutes late or has to step away for that long may continue to attend the webinar, but they may not receive credit. You can search for my name, Alvin, in your inbox, and that's how you can find your certificate if you don't see it when it first comes in. We're running a little late on other certificates as well, so just keep an eye out. They should start coming out soon. And make sure the name on the screen matches the one that you want on your certificate. And if you don't know how to change the name on your screen, you can drop that in the chat and we'll see what we can do. And if everybody else would like to go ahead and put your cohort in there and everything, that would be great. And I am going to launch the first poll, the one we always do. Who is here? So if y'all see that and start answering it, there we go. I see it's coming through. We'll leave that up for just a minute longer. We are over 100 participants today, which is really good. All right, I see that 78 people have answered. If any of y'all can respond, are you a CARES? Do you aspire to become a CARES? You a clinician, a recovery ally, or someone else? All right, we're up to 88. That's 86% participation, so that's good. All right, I'm going to end the poll and share the results. Can you all see that?
Mr. Alvin, may I ask you a quick question?
Yes.
I had somebody ask me if they are a CPS mental health, are they able to use these as continuing education credits?
They are, and y'all
Okay,
can email me with any questions you have.
sure.
All
Thank you.
right, but yes, these are available. I'm going to get a picture of that because we'll need this information.
I'm sorry. I'm sorry. One more question. I'm Bruce. I'm both aspiring and a recovering ally. Did I have the ability to choose both and I didn't do it?
Nope, that's
Okay.
fine. This is
Okay.
just good for us to know. So
Thank
I'm
you.
gonna stop sharing. And please feel free, I'll stay around after. If anybody has any questions at the end, just write your question down for me. All right. So today's presenter, Shannon Rapier, is the director of the Freedom Collective and a dedicated advocate with 7 years in the anti-trafficking field, a certified alcohol and drug counselor, and a peer support specialist. She combines professional expertise with lived experience, bringing a trauma-informed perspective to her work. Shannon is also an instructor with the Institute for Shelter Care, teaching the Triune Care model for stabilization shelters, which supports those serving trafficking individuals in the critical initial phase of care. Shannon, thank you for the great work you're doing and for coming here to tell us about it.
Thank you. Thanks for having me. Um, well, hi, everybody. So I saw that we had some clinicians on here. I just want to go ahead and say that I do not have a medical background. And so I am speaking to you guys from not only lived experience, but also the experience that I have had working in an emergency safe home. And so, so if there is something that I say wrong, please let me know. I am completely open for advice, feedback, all of that, because we're all here to learn, right? And so I'm going to learn from you guys just as much as you're going to learn from me today. And so I'm just going to share a little bit real quick. So trauma and substance use both hit home for me personally. And then just being called to work in the anti-trafficking space has been very hard, but also very rewarding. And so today I'm going to share, we've got science behind it, we've got statistics, but I'm also going to share, just personal experiences while working in an emergency safe home. And what an emergency safe home is because I want to go ahead and just clarify what that is. So you guys, when you guys hear me talk about it, you will know what that means. And so I run an emergency 24-hour crisis stabilization safe home for survivors of sex trafficking and commercial sexual exploitation. And what that means is we do 24-hour intakes. We operate a 24-hour hotline, and we focus solely on crisis stabilization. And so what we do is we focus on physical safety, and then we start really processing and trying to get psychiatric appointments. I do addiction counseling with the women in the safe home, and we have outsourced referrals that we make as well. And the women are with us roughly 30 days, and what we have a lot to do in that 30 days. But the biggest thing that we do is we find them that long-term aftercare from us. And so we partner with 75 long-term programs across the US. And those programs really focus on that inner healing. They focus on that deep counseling and processing the trauma. If you have been on other webinars, they're about trauma and addiction. We always talk about how we don't necessarily have that addiction problem. We have a trauma problem. And I will say 85% of the women in our emergency safe home have experienced and expressed that they have some type of substance use addiction in their background. And 100% of them have expressed some type of childhood trauma. And that is wild to me. It's the world that we live in. And so today we're going to talk through just different types of trauma. I'm going to share some stories. I will not be sharing names. If I share a name, it's going to be a name I made up, or my own name. I might use myself. I have no idea. We'll see where we go from here, right? As I jump in, I'm going to first start with what's right with me today. And what's right with me today is the opportunity to get to be here with you all. My CARES family I've been a CARES since 2017, and my CARES family has just been so close and dear to my heart. And I've learned so much. And I'm going to share more about what I've learned towards the end, and just how CARES has inspired me to do some things on my own. And so I am going on 11 years in recovery. And what that means for me is I have not had any mind-altering or substances. August 19th will be 11 years for me. And when I hit that decade, I was really like, man, I hit a decade. But now I just keep getting excited because those years keep growing. And I'm like, this feels good. It feels right. And it's where I'm supposed to be. And so super excited to celebrate that as well. So thank you all for being here, and I'm going to jump in. Oh, let me make sure. So, Alvin talked about this. So you guys, we already know what that is. And so these are the definitions. So this, trauma, is emotional or psychological distress resulting from adverse or life-threatening experiences. Substance use of a substance, alcohol, drugs, etc., to alter mental or physical states, sometimes leading to dependence or addiction. And so trauma is our leading factor to substance use disorder. When in the safe home, when women say, "Why do I use?" And I'll say, "Well, I don't think you just woke up one day and said, 'Today I'm gonna start doing meth.'" I just use that one for an example. And we'll talk through the aspect and the opportunity to say there was something that you were trying to fill. There was a void, there was a hurt, there was pain that you wanted to cover up. You maybe just didn't want to deal with everyday life. And substances in the beginning seem like the easy way out. I do know for me, starting at 9 years old of doing opiates, I know, very young, but that was a way out for me. And that was a way that I did not have to deal with my childhood trauma, but also deal with the world around me, and the family that I had around me. And so with that, just thinking through, like, when we talk about trauma, it's both subjective and cumulative. And so it can be something that's one time, or it can be over a period of time. And just remembering that what overwhelms one person may not impact the other person the same way. And so we talk about how there's so many different pathways to recovery. There's so many different pathways to healing. And there's also so many different types of trauma that affects people in multiple ways. And that is one thing that I have seen over and over again, in our safe home, and also just personally. An aspect that may affect me, and my husband, who is in recovery as well, it doesn't affect him that same way. So if a trigger comes up for me because I had childhood abuse, sexual abuse, he did not have that. So something will trigger me that will not trigger him. But the beauty of that, and the beauty of relationships, is he's able to help me come out of that. He's able to see that for me, and he's able to say, "Hey, I see that this is affecting you, so let's talk through it." And so we talk a lot about relationship and cares, and relationship and connection. It's so, so important. And so, yeah, I'm just gonna keep going my way, keep on going through. So just some trauma statistics. So everybody's heard of ACE. If you have not, ACE is a adverse childhood experience test quiz. You can find that online and you can take it. So if you have not taken that, I advise you to take it. It is something that it's short. It is 10 questions, but it will actually tell you a lot about childhood trauma that maybe you didn't realize, or maybe you haven't started processing, or maybe it's something that you want to learn about so you can process more of your past trauma if you have that in your background. And so, if you look at this, people with an ACE score of 4 or more are 7 times more likely to develop substance use issues. And so that really highlights the childhood trauma and substance use. And so that is something that, a lot of people don't correlate, and they don't put the two together. They just think that I have an addiction or I have this problem, but they don't realize what the root of the problem is. And so I did go through an intense inner healing program. I was there for 21 months. It was really long. But I was also very stubborn, guys. Like, I'm just gonna own it. I was stubborn. I got in trouble. I didn't want to listen. Um, and that's okay. But I also needed that extra time for me. I'd say 21 months in an inpatient program, and people are like, whoa, that's a really long time. Yes, it is. But that's what I needed to be able to get to where I'm at today. Um, but in that program, we really focused on the root. We really focused on the why, deep down the why, not necessarily the addiction specifically. We focused and we really started processing the heart behind what was going on and the actions from the childhood trauma. And so when you think through just kind of what trauma maybe you have experienced or trauma that you have heard from the clients and those that you are serving and working alongside, you think through the opportunity of looking at their childhood trauma a little bit differently. And you think about, okay, instead of just focusing on the addiction or the behavior itself, let's try and dig a little deeper and let's really process, deeper of what has happened and why and how we got to the addiction versus just focusing on the addiction. And so, trauma is something that we, again, have experienced so much. And when working in this field, working, whether it is an addiction specifically, or for me, working with sex trafficking victims, it is something that goes hand in hand with addiction. And it goes hand in hand with mental health. And so we navigate all of those things in our safe home. Um, and so as you think through, just kind of looking at here is our childhood adverse experiences pyramid. Right. And so if you start from the bottom and you kind of work your way up. And so thinking through it includes different things like abuse, neglect, household dysfunction, um, and thinking through, over 60% of adults can have one or more of these. And that is something that's a huge number. And it's because you can think through there's something small or you can have all of them. And so disruptive neurodevelopment, that's chronic stress in childhood stages of the brain. So especially areas of emotional regulation and impulse control. And so when kids experience trauma, they kind of stop developing in a way that they are not able to process their emotions. There's a really great video that I'll actually share with Al, so maybe he can share that with everybody else. I should have put it down today, but completely forgot about it until just right now. But there's a video of a mom. It's a doctor. It's a science experiment, and it's a doctor who's overseeing it. And there's a child who is crying for a mom, and then when the mom interacts with the baby, then it's probably a 2-year-old, 1.5-year-old. The baby like really stops crying, and you can see the shift in the child. But when the mom just kind of stops engaging, the child really gets upset. And it's a very interesting video that we share and that I've watched quite a bit to just kind of understand where children, where their thought process is just as children and just how their emotional regulation takes place. And so then you think through like your social, your emotional, your cognitive impairment. And so this is like where kids have, they have trauma that has impacted them often, like that struggle, that helps, they have struggles within school, relationships, again, regulating those emotions. And this is kind of setting that stage for risky behavior. And it is something that, when you think through just kind of children who you see in elementary school, maybe middle school, and they start getting in trouble a little more. And, for me, it's hard because I look at the world in a trauma perspective. And Even with so I'm in school right now as well in college, and the coursework that I have to do in college, it has I'm reading these stories. I'm doing English composition too, and I'm reading these stories, and I realized in these stories that my brain, everything that I focus on, or everything that I read in the story, I shift it I look at it through a trauma perspective lens. Whether that's good or bad, I don't know. But my professor says, you've looked at this completely different. And I was like, man, so I don't know how to necessarily get out of that. So I look at things in that perspective, probably because I'm immersed in trauma all the time. And so it is something that when you're thinking through children, I pay attention to behaviors, even my own child, and just really, okay, how can I help shift? How can I help navigate this? How could I help her regulate her emotions? Um, and so then you think through just that adoptions of high risk behaviors and crimes. And so this is where, that substance use often sets in. And that's where that's where we start coping with the pain of our trauma, coping with things that we have dealt with, not dealt with, the abandonment, the rejection. There's so many things that may have happened. And one thing to remember about this aspect is it's not about rebellion. This is about relief. So when the addiction sets in, they're not trying to rebel against the world. They're really trying to find some relief in the life that they have set around them. And so that is something that when I became a CARES, and we really started talking about how there's many different pathways to recovery, that is something that really sits close to me, and I just hold on to that because if you listen and you hear somebody's story from childhood up, or from as long as they can remember, what worked for that person may not have worked for me, or what worked for me may not work for that person. And it's because maybe we both experienced trauma and we both have some similarities, but the way that that trauma affected our life turned out differently, right? And so you have to think through like what works best for those that are around you, and remembering to be open-minded as we're helping others. And so disease, disability, social problems, that is just, where your trauma leads to long-term issues, your addiction, mental health, incarceration. And just remembering that it's not because of weakness, but it's unresolved pain. It's unresolved trauma that they have not had the opportunity to process. And so coming alongside, we're going to talk about what trauma-informed care looks like here just in a few minutes, but coming alongside somebody and saying, okay, let's deal with the trauma versus let's talk about your behavior. There's a light bulb switch that you can see that happens. And also remembering, helping encourage them and saying like your behavior doesn't define you as a person. Your behavior is a result of situations that have taken place in your life. And so also, ACE scores, it talks about early death. And so that's those with high ACE scores. They're higher risk for early death, but healing trauma and really helping change that path can help solve that. And so just looking at this pyramid, just so everybody knows, you will get a copy of these slides. Please take them and share them, talk about them, like do whatever you need to do to try and help others in this aspect. But this pyramid can help us see that treating addiction means treating trauma, so starting from your bottom up. And so starting at that childhood trauma. So this pyramid specifically you can find online, but you will get copies of these slides. And so you think through different different types of trauma. You have your acute trauma, and that's just a single overwhelming event. And so that can potentially be just like an assault, a natural disaster. That can be something that is not necessarily repetitive pattern, right? And then you have your chronic trauma, and that is your repeated exposure. That's your abuse, your neglect, trafficked victims. That is, those that have continuously lived in poverty and continuously had to navigate what life looks like, and not like that was, maybe that wasn't a choice that they chose to do, but maybe that is just how their childhood started, and so they continued those patterns. And so then you have your complex trauma, um, and that's your generational trauma. That's that trauma that, just really starts from childhood, and it just grows and continues to happen over age or over time. And so you think about somebody who had sexual abuse at 4 years old from a parent. So I'm just going to use that as an example. And I do want to disclose that some of the things that I will say today, they are hard to hear. And so please take care of yourself. Please make sure you have your water, take a break, walk, whatever you guys need to do in that moment, to be able to listen while also caring for yourself. But so if you think about, say, a 4-year-old who was raped by her father, and it wasn't a one-time event, it was a repetitive event. And so that is the complex trauma that she has grown up into, and that is something that she holds onto, and that trauma helps determine the pathways for her life. And she probably started and can start substances at a very young age because she's trying to escape that trauma and she's trying to escape that feeling. And so that is something that, again, I see day in and day out, and I help process with women in our safe home. And so, just thinking about historical trauma is something that can, contribute to their vulnerability. When somebody has experienced so much trauma as a child, they just really sit in that as they grow older, and they are put in more vulnerable situations, and not even meaning to. It could be their perception of how they present themselves. It could be the opportunity of how they talk to people. You know I like to say the company you attract in is kind of how you can feel about yourself. And so if you are attracting people that can continue to hurt you, that is probably something that's unresolved childhood trauma. I see a hand raised. So Denise, let me go ahead and call on you.
Thank you, Shannon. Very good presentation.
Thank
Um,
you.
the chronic trauma and the complex is very similar, it looks like, because the complex, as you was just describing, is also repeated because this child had just been in this repeated exposure to her dad, right?
Yes, it is. And so they are very similar. So that is a good point to make. So thank you for bringing that up. Um, and just thinking through, when trauma overtakes a child's life and they grow up into that, they could potentially repeat that trauma as an adult. And so if they have continued the situation with the 4-year-old little girl, continue to be raped by her father, well, then as she grows up and she's out of that situation for whatever may have happened, then she's put herself, not by choice, in more vulnerable situations, and maybe she's potentially raped again as an adult. Um, and so just remembering that, all types of trauma, they require, approaches, and they require treatment. And so there's many different types of treatment that you can have for trauma, outpatient, inpatient, just like substance use, right? And so I mentioned the 75 long-term programs that we use. Some of those programs are specifically for sex trafficking survivors. Some of those programs are specifically for addiction. Some of those programs, they have so many different attributes to these programs, and some of their requirements are very different. But the one thing that they really have in common is the trauma piece of it, right? Is the really processing that trauma. And then it just, victims of trafficking, they may experience all three types of trauma. And that is something they may share, within, experiencing, talking alongside somebody. Some of the people that you guys may serve may have never brought up and have not shared that they have been trafficked, or they have had to, we call it commercial sexual exploitation. That means that you've had to trade some type of sexual favor for food, drugs, money, a place to live. That's the legal definition of it. And so, we really talk within the Freedom Collective. We talk in person first language, and so we really talk about how we don't say addicts. We say somebody experiencing substance use, somebody experiencing addiction, somebody experiencing prostitution, somebody experiencing something, because we don't want them to think that that's their identity, right? Like, we want people to help and learn who their true identity is, and maybe they've never had the opportunity to do that. And so we really talk through and try to use verbiage that is empowering and uplifting. And so when it comes to trauma victims, it's you see a light bulb when you say, hey, your circumstances do not define your identity as a person. And that's really hard for somebody to kind of take in, because they think and they say, well, I am just this is all I'll ever be. And so, and you can fill in the blanks with all the things there. And so we really tried to navigate and break down false beliefs about themselves. And so it's very important to us to make sure that we talk through person first language. Okay, so the science behind trauma and substance use. And so we talk about how substance use can impact us, but then thinking through, trauma impacts our amygdala, that's our fear processing, our hippocampus, that's our memory, and our prefrontal uh, cortex, and that's our decision-making process. And so if you think somebody who's in survival mode, from whatever reason they are in survival mode, they are not able to fully make sound decisions. Somebody in addiction cannot make a sound decision. They make very impulse decisions. And so then you think through, how we self-medicate. I am sure everyone on this call can raise their hand and give me an example of how you self-medicated in whatever capacity. And so that's just how we want to numb the pain or cope with distress, right? And so as you're talking and processing with individuals that use drugs or alcohol as a way to cope with distressing psychological symptoms, you really want to start saying, okay, let's see where that's stemming from. Let's see, is that stemming from, trauma that has then led into the anxiety, the depression, the unresolved emotional pain that they have from the trauma. And so they are self-medicating. And then we talk about like our cycles of dependence, and, cycles of dependence, that is that temporary relief, and it often worsens our symptoms. It often gets worse as we say, okay, well, I don't want to deal with this, so I'm going to go numb by using this. And so as we undealt trauma, it changes our brain function, and so we make those impulse decisions, and we don't necessarily have the correct, I say correct, what's right, what's wrong, but what's the best way to look at it, but we don't have that control over our bodies and our thought processes to be able to say, today I'm going to make this sound decision, and I'm going to make the right decision for me. What's right for me, again, is not right for somebody else. And so we have to really think through, when we have those impulse decisions, and we're not processing why we are using substances, that is where relapse can be higher. And so, trauma survivors, they often live in a state of chronic hyperarousal, which makes, the temporary calming effects of substances appealing. And so that, where we want to calm ourselves down, that is why we want to use a substance. It is easier, and I'm sure most of you can relate to this. It is easier to say, I'm not going to deal with this and I'm going to numb out, right? And so when you are serving along someone as a peer, calling them as a counselor, as, trying to call them out of their specific situation and help call them to a higher standard, they may not necessarily know or understand why they want to continue to use substances. Maybe they don't understand how trauma affects the body, how trauma affects the brain. And so thinking through our next one, you have your just different brain functions, and you think about when like trauma, it can, what it does is it affects the brain and it can cause higher, like just our processing is not the best. And so when it comes to our brain, as a child, you're supposed to go through these stages of brain development. So as a 4-year-old, you're raped by your father, okay? This 4-year-old, her brain in that moment can stop developing the way that it is supposed to. And the trauma sets in and kind of overtakes her. The amount of women that I have experienced and I have encountered in our home to where they're developmentally stuck at their trauma. And so we have women who don't know how to read, who abuse started at 6 years old, and that is where they are stuck. And so helping them try to navigate and get out of that is, really processing that aspect of their trauma. And you say, okay, you can see their thought processes and their lack of decision making because they are stuck at that trauma. That trauma event that took place in their life. And as we think through, as we think through the brain and the scientific aspect behind it, again, this is really dissecting the brain is not my specialty, but I will say that if you think there's so many different videos that we could watch about the brain and how the brain impacts the trauma or how trauma impacts the brain, right? And so as we, there's so much more that you guys can look at. There's so many different videos online that will probably explain it way better than me, from that medical perspective. But just remembering that, trauma survivors, I'm going to say this one again, just because it goes hand in hand, right? So trauma survivors often live in a state of chronic hyperarousal, which makes temporary calming effects of substances more appealing. And so if they are in this hyperarousal state, and they cannot bring, have you guys heard of the window of tolerance, right? And so if you talk through your window of tolerance and you have to figure out like where you're at. And so in that hyper arousal, the women that we have encountered and anybody who is using substances who have experienced that trauma aspect, they don't know how to ground themselves. And so we want to help introduce those coping skills. We want to help introduce that aspect of grounding to try and bring their window of tolerance to equal levels for them. And so trying to find those calming effects that are not substances. Sandra, I will go ahead and let you.
You're doing a great job, Shannon. Thank you. Very informative. I just wanted to say it seemed like when you're talking about getting stuck, I had no idea how stuck I was. Like I got clean at 52 years old, so I spent decades. But when I started to, heal and things like that, I realized I was stuck back at the age that I was when I first started using. I learned that through, different fellowships and stuff. But it was so ironic how you know, I didn't think anything was wrong until I look back it with clarity, you know, because everything was so grandiose, you know, everything that was happening to me, it's like I was the only person it was happening to. And so you get stuck in that way. You make such a big deal out of everything. And I think it's just your mental state, like you were saying, the way you know, it's just the way you see things. It's just everything is like, you know, and of course, any excuse will do to use any minor mood altering substance. But I just wanted to tell you that that was really good about how the young, you know, like how young you are. And at 52, I felt like I was 17 once I got, you know, clean and everything. But great job. Thank you.
Well, thank you for sharing that and being vulnerable in that moment. That is a great example of, getting stuck, and just how trauma affects us so, so much.
Question.
Oh,
Can I jump in? I don't know,
yeah.
my hand is not showing up.
Oh,
This is it.
okay.
I'm person long-term recovery. I have co-occurring. This is where we're headed from. And I wrote somewhere the body keep the score on how something I had early childhood abuse. I thought I dealt with it. Then the World Trade Center, that thing happened. And guess what? I'm in therapy. I'm not talking about the World Trade Center. I'm talking about all that other stuff. I mean, I had to work through that. But one of my challenges working with peers, and I just want to get your feedback, is I taught RSAT in the jail. I sometimes teach classes as accountability court or peers coming in for peer coaching. We can show them the slides about the science. All of our programs we run, we do fun programs where we do education, all science based.
Right.
Even when you show them the scans on the effect on the brain, there's just you can talk about grounding skills, but grounding skills, which have been a lifesaver for me. But it's a challenge. I don't know what your experience is, but you show it to them and like, oh yeah, oh yeah, oh yeah. And that's probably the majority. And maybe that's how substance abuse is. Those few in their own time. I don't know. I'm just throwing it out there.
So you're saying that you show them the scientific aspect behind addiction and just how it affects them, but they don't really receive it or they don't comprehend it. What can you explain the
It's
question?
both. It starts out with trauma. I taught a men's class in the jail.
Okay.
Okay. And hey, anybody in here have trauma? Not one, right? So I throw mine out. And
Gotcha.
then it goes, well, my friend, when I was 9 years old, I saw him blow his brains out, all these things like that. And so it opens a discussion. But it seems to end there. There's a problem with, I look at us as we're in between, say, the court system for many and
Right.
those who don't have any clinical opportunities. And so there's this gap to try to help them. We can do peer coaching, and I'm a 12-stepper with AA. That really provided clarity and continues to provide clarity for me. But we got this hole in trying to get them. We can't make it click. They're down on themselves. You're telling them this, and they just don't get how all of this affects their behavior and the decisions as you were going. So maybe if we figure that out, we'll solve all the problems of the world. But that's I've been thinking about that for a long time, and so I just wanted to get your take on that.
Yeah, and there are times that and I just experiencing this just like you have, there are times that you can ask, well, have you dealt with trauma? And nobody says anything, but then someone mentions something like that. But then you have to say, okay, that is a childhood trauma. That is something, and then you can even go back to that acute trauma. You can like literally put the words behind it and explain to them, like maybe it was just the one situation that you saw, but that acute trauma affected you. And it was unresolved trauma, and so they never processed that. There's so many people who don't correlate the childhood trauma that they experience with why they use substances, and so it is something that you can't force, right? You can't make somebody know and understand. Also, there's people who don't even want to acknowledge it. They don't even want to pay attention to it. And that, that is something where we can be as peers, we can say, hey, this is what I'm seeing. This is what your unresolved trauma, just by what you have shared with me, this is what that unresolved trauma is. But it's their choice if they want to deal with it, if they want to process that. And if they don't, unfortunately, that is something that they continue to hold on to. And for people who have never processed that trauma and felt the freedom on the other side of that, they don't necessarily know and understand what it feels like to actually process the trauma. And then there's a sense of fear. I believe this is in one of my slides later on, but I'm just going to go ahead and say it. There's that sense of fear of what is it going to feel like to have to deal with this? There's that sense of fear of having to go back and relive those memories. They have shoved those memories so far down that they are not even willing to dig them back up. And there's a fear of having to feel what that's going to be and navigate. And maybe they don't know how they're going to react to that. And so there's so many different things to navigate through that. My husband is an addiction counselor, and he worked at a men's regeneration program in Dahlonega. And he worked there for 9 years. And, there was so much, and he would share with me, he was like, the men, they have fear of feeling those feelings. They have fear of processing. And so that is, that's just the experience that he has shared with me. And it just resonated so much with, we don't necessarily want to deal with that. And so that could be a potential there. All right, Amanda, I see your hand was up. I'll let you go ahead and ask your question real quick.
So Shannon, do you want people to drop some questions in the chat also? I don't want you to get too far behind.
Yeah, we can do that. If you guys want to drop them in the chat, Amanda, since I went ahead and called on you, I'll let you ask your question. But Melissa and Shelly, if you guys could drop your questions in the chat, and then at the end, we'll make sure we take time to answer those.
So my name's Amanda. I'm a person in long-term recovery. What that means is it's been 8 years since I've used any illegal drugs or non-prescribed prescription medications. It's really not a question. I just wanted to share that I'm so grateful that you are doing this today, because like when you said you live your life like in a trauma sense, I do too. I'm like super open about my traumas, but it's like I need to find that therapist that's going to dig in me and pull me, because my biggest thing is that I was molested, and it happened one time when I was 3.5 by a cousin that was old enough to know better. He was a child, but it was very what would I say? It was very, not abrasive. I don't know the word, but it wasn't. It was very bad. And so I dealt with that until I learned about. I thought I was nasty, and it just went through my head all the time until I learned about good touch, bad touch in school, and that saved my life, and it freed me. And I felt like I never thought of it again. My thing is it's like I used from 19 till I was 30 years old, and became an IV user when I was 30. But I know I used because I had trauma, but I never remember thinking, about something and then using, if that makes sense. But I know it stems from that. And I don't know, I just wanted to share that, and you kind of spoke about that a second ago. And I definitely agree with you. Like, everyone has their own time when they're ready to deal with that trauma. Some people, especially, I know a lot of men, my fiance's in recovery too, it's hard to relive that or accept that it's trauma going on. I do, and I want to I want to share, and I want someone to dig into me and pull things out of me and let me share it all. But thank you so much for doing this, and I needed this today. This is awesome.
Oh yeah, well, thank you for sharing and being vulnerable today with us.
You're welcome.
So I'm going to keep on going through. And so just remembering that, you know, people don't always use substances to get high. We've talked about this a couple times already. And so, you know, numbing that emotional pain, regulating their overwhelming emotions, and escape from intrusive thoughts or flashbacks, and then, you know, just reducing anxiety to help with sleep. There are so many women who we've encountered who cannot sleep in our home, and that's for many, many reasons, right? So they can't sleep because most of the time when you're being trafficked and or commercial sexual exploitation, it does happen a lot at night, and it's a very fast-paced lifestyle. And so when you come into our safe home, you know, we'll talk more about trauma-informed care here in a second, but when you come into our safe home, it's very calm. We have calm colors. We have a calm, you know, every aspect about our home presents calmness. We have homes that are not in the city. They are not, you don't hear, you know, maybe trains or planes or buses or a lot of activity. I just moved to Florida, and so I'm launching a new chapter here for the Freedom Collective. And our home here in Florida, we're on a 33-acre farm, super quiet in the middle of nowhere, right? And so it's going to be very different. And so when the stillness of the night sets in, it is very hard for these women to sleep. They're not used to sleeping at night. And then also people who use substances, you know, rather depending on that substance that you use or that you did use, you know, your clients may not be able to sleep at night. And so, you know, finding that opportunity to help them to reduce that anxiety to help them sleep. We talk a lot about how sleep is so important for our body, right? So you have like the holistic approach, and sleep is like number one. Like it is so important for us to get, you know, they always say 8 hours of sleep, but a lot of people don't get that 8 hours of sleep. And so a good 7 hours, you know, it's so important. And so you know, we have it set in stone of like 10 o'clock is bedtime. And then, you know, you have to be up no later than 8. And so we really try to give them that extra time. But there's so many women who have sat in their beds who cannot sleep, whether they have nightmares, whether they're thinking about the lifestyle, whether they're missing their trafficker, because that is a huge thing for us, for the women that we encounter. And so, you know, there's being able to escape reality to do the things that they need to do also feeds into why they use substances. And so, you know, as we think about and we talk about, you know, you have your different types of trauma responses, right? And so you have your fight, and that's that aggression, that impulsivity, you know, may lead to more substance or misuse. And so that is where they are really trying to, you know, they have that outward aggression towards others around them. And you know, when you're in your fight, flight, freeze, or fawn mode, this is your automatic nervous system responses. And so it's not necessarily choices, but it's your survival mechanism. And so many people can figure out, hey, I've been in fight or flight or freeze or fawn. And so your flight is your avoidance behavior. And that can manifest as resilience, like reliance on substances. And then you have your freeze, that's your emotional numbing, and may increase more towards addiction. And then you have your fawn, and this is like your codependency, and this is substance use in a toxic relationship. We see this one a lot in our home, just dealing with survivors. They are so codependent on their traffickers, and that's because their traffickers have made them that way. They use that force, that fraud, that coercion to manipulate and to get them stuck to where they are reliant on their trafficker. And then also traffickers use a lot of substances to feed to these women and or men. So I say women because we only serve women in our home, but there are absolutely men who are trafficked, and we help them, just not in our safe home specifically. And so, you know, the fawn response is often overlooked. And so because it involves people pleasing and can show up and just, like I said, trafficking survivors who are attached to their abusers. And, you know, Fawn is going towards domestic violence. We can add that in there. So many people, you know, who get stuck and feel stuck and they feel like they are codependent on that person and they cannot get there. They can't get out. They don't know how to get out, and nor the fear of leaving that unhealthy or that abusive relationship is far greater than the fear of staying. Something we see a lot within trauma is, you know, in a trafficking situation, they are used to that. That is normal to them. Unfortunately, I hate to say that, but that's the truth of the matter. They have more fear of leaving and getting out and seeing what the world looks like differently. And so the amount of women who have said, I want to leave here, I'm not ready to go to a program. And we do what we call play the tape. And so I'll sit down and I'll say, okay, let's talk about what's going to happen when you leave here and when you go back to John. And they're going to say, I know what's going to happen. And we'll talk through and they're going to tell me what's going to happen. That is the hardest thing to hear. I am a full firm believer in the Lord. And so I have to rely on him a lot to do this work, because the things and the stories that I hear, there is secondary trauma. And so I did not put this in my slides. I should have though. But there is secondary trauma to where we take on and we experience trauma through somebody else's story. And that is something that I have experienced a lot. And so I have to have my own coping skills and I have to be able to navigate how to help the person sitting next to me while being able to care for myself. So I talk a lot about self-care. I do a lot of trainings on self-care and what that means, and how people can care for themselves while still also caring for others. Because when you get into recovery, we want to give back. I know that most of you on this call have been like, okay, now I'm in recovery. Now, how can I help somebody else? Right. And so whether it's profession, like that's your work field, whether that's your volunteer, and there's so many different aspects. And you're like, how can I give back? But if you don't care for yourself while giving back, then you're going to burn out and you're not going to be able to care for that other person. I say a lot to my staff. I have, I have overseen staff all the way down from 9 to 25 25 person team. And I say to them a lot, you can't give what you don't have. So if you're completely burned out and you're not able to care for yourself first, then how are you going to care for somebody else? Now that sounds very selfish in a lot of ways, but the truth is if I don't have something to give to you because I haven't been giving to myself, then I'm hurting you and me. And so we have to, in this field, whether it's you're working with somebody in addiction, with trauma, trafficking, mental health, you have to be able to care for yourself, especially when you hear those stories and you take on that secondary trauma. With that, when I leave the safe home, I have this little thing that I do. And so we have keys for the safe home. And so I wear my keys around my neck. I have them on a lanyard. And when I leave the safe home, there's a gas station right down the road. I take my keys off at that moment, right at that gas station, and I say, I'm leaving this right here. And I'll put them in my seat. And I'm leaving work where work's at, right? And I'm leaving it at that gas station. And then the next morning when I come back, I'm picking those keys up as I'm passing that gas station. It's just something that has helped me for so long being in and immersed in trauma to be able to separate the two. And
So
so
Shannon, you had asked for a time check. We have about 30 minutes left.
perfect. Thank you, sir. So I'm going to try and get through these. I did tell Al, I said, hey, I've got stuff on my slides, but I can talk a lot. So substance use, we use that as a coping mechanism, right? And so it can help mask just our flashbacks, our anxiety, sleep issues. It can help be able to escape reality. And so, understanding that these struggles help to address barriers in recovery, when you say, "Hey, why are you using?" Let's really talk through that aspect. It can help that person to be able to recognize what is happening. And just remembering that, using a substance is not they're not using it just because. It's a survival strategy that worked for them until it didn't. And so that is something that the substances that are out there today are wild to me. They are nothing like the substances I did 11 years ago, right? Like it is. People are passing away left and right, unfortunately, and it is so hard because the addiction world and the drug world, people who are selling those, they don't care for the next person. They're only caring about the dollar. They see money signs on people. And that is something, whether it's the substances, it's the trafficking, however it looks, people put dollar signs on us when in all reality, we have so much value that no amount of money can put on us. And so, when we're talking about recovery, when we're talking about, what we should address, we want to talk about the why. I cannot express this enough. We want to talk about the why and not just the behavior itself. Going through that deep inner healing process and literally staring my demons in the face was the hardest thing, but most freeing thing I've ever done in my life. And the 21 months that I was there in the moment looked like a lifetime, but after the fact, looking back, it was just a small portion of my life that had helped me process that unresolved trauma from childhood. And so, also one thing I'll say is as a trauma survivor may use opioids not for the euphoria effect, but to sleep through the nightmares, reduced pain, or the reduced panic attacks, and just to have to navigate everyday life. And so you think about, what are those barriers to recovery for trauma survivors? This is a question I'd like for you guys to answer in the chat. So how can we reduce stigma in treatment environments? That is something that we have encountered so much in so many different treatment environments. And, how do we reduce the stigma and say, okay, let's process what's really going on versus just dealing with that behavior. And so, the different barriers that we have and that we talk through are the fear, the stigma, the lack of trauma-informed care. When we take women to the hospital, and which is why CARES was presented, right? Or created. We wanted to be able to approach things as a peer-to-peer. When somebody relapses or somebody overdoses and they're taken to the hospital, they don't necessarily want to talk to the doctor in the white coat, right? The doctor cannot relate, cannot understand why I overdosed. They want to talk to that peer. They want to talk to somebody who can understand. And that is where we, even the same thing with trafficking survivors, talking with that peer aspect, but also the education behind it and going in and sitting next to them and being an advocate for them. The amount of times that we have went to the hospital and we have sat with a survivor who had truly escaped a trafficking situation, and she, was abused and all the things that she went through, but she also had addiction, right? She used addiction to cope with the trauma and to get through her trafficking situations. And the amount of times that the hospitals, doctors, they would look at her and they would say, she's just an addict. And they would not pay attention to the trauma. They would not pay attention to the physical aspect. They would just put that stigma on her, and that's how they would treat her. And so being an advocate, having us as peers to walk alongside somebody within their trauma healing is so huge and so important. we think through like these roadblocks that they come up against, they may not know how to navigate. They may not know how to say, okay, this is what I'm feeling right now. And so we want to help break down and we want to remove those roadblocks through the awareness and through training and through education. One of the things, the biggest class that we teach on a very high level in our safe home is how trauma affects the body. There is so many different, resources that you guys could look at, but one of the biggest things we do is what we call a body scan. We utilize a lot of grounding techniques, just a lot of different coping skills, but the body scan is where you truly sit in a quiet space and you start processing, like start working your way through your body, just mentally, starting with your head. And you start paying attention to what is happening throughout your body. You notice the tension that you have in the back. You notice the tension that is going down your spine, and you start saying, okay, this is what I'm feeling. And so we start really trying to put words and feelings to the tension in their body. And we start saying, okay, and really learning where we carry our trauma. Where do we carry our stress? I know I carry my stress in my lower back. And so when my back starts hurting, I can tell that I just kind of need to take a step back and do some self-care for me. But we really want to try and help others know and to evaluate their body to be able to say, okay, I'm feeling this tension and this pain. How can I overcome this roadblock? And so, being able to help navigate where we're at when it comes to being a true peer, standing next to somebody who says, hey, I do have addiction, but I also have trauma. I have unresolved trauma. I know I don't have that much time, but I'll tell you one story. So, we had a woman in our home who would make decisions, and one time she swallowed like a shaving razor head. And I'm like, whew, okay, so how do we have to navigate that? We take her to a hospital, and they kept her for like 3 days. They made sure she was going to pass the razor head. It did no damage. Praise the Lord for that. And then they sent her back to us, and we're like, okay. And so, they helped navigate, put her on some medications, trying to stabilize her. Well, the second time she took unscrewed screws out of our walls. And so we don't hang things up with nails. We're very specific just because that trauma-informed care approach, but also we have a lot of women who experience suicidal ideation in our home and also have attempted suicide in our home. And she unscrewed screws out of the wall with her fingers. And so she swallowed those. We took her back to the hospital and they were like, this was an impulse decision. And I said, well, I'm so sorry to the doctor. I have to disagree with you because it took her a little while to unscrew these screws. It was not impulse. It wasn't like I'm just doing it right now. It took her some time. And so then we started talking to the doctor and started expressing more that she did not share with the doctor. She did not open and disclose. And so we had to do, confidentiality and sign all the paperwork. And we're like, okay, how can we really care for her? Ultimately, at the end of the day, it was unresolved trauma. And that's what the doctor was like, okay, she seems to present, besides the actions, she presents well. She presents that, that she's okay and she does not want to kill herself. That's the biggest thing. She's not trying to kill herself, but that is her response to her unresolved trauma. Ultimately, we ended up having to get her to more inpatient stabilization and longer term care inpatient, just because we were not able to watch her 24 hours a day. And so all ended well. She was able to get to a program, to an inpatient facility that would help navigate that. But it just really goes to show the unresolved trauma. We have our own ways of processing that and or not processing and covering it up. Whether that can be the addiction, different types of substance uses. There's so many different things we can be addicted to in life. And one of the things that we experience a lot is self-harm, and that was hers. And self-harm was huge for her in her life, and that's how she coped with life, unfortunately. And so, Trauma-informed care and substance use treatment is so important. And this just isn't trauma-informed care principles. It's about your safety. It's about the trust. It's about the collaboration, empowerment. And then you even have your culture around you. And so we want to make sure for us, and what we do is we really talk through and emphasize just how can we, not only do we create a trauma-informed care environment, but also how do we create a trauma-informed care case plan with these women that we serve. And so we talk about, empowering them, bringing them into decisions. We don't make decisions for them. I can't make a decision for somebody else. I can say, here are your choices. Trauma-informed care, this is Shannon's verbiage, nobody else's. But it is something that I just kind of took on. And so trauma-informed care is choices within boundaries, especially in our house. We can't just say free for all, you can make whatever choice you want. We have to have some boundaries within that, right? Like we have to keep our home in a non-disclosed location. We have to make sure that we can create a safe environment for everybody. So we give choices, but there are boundaries that are put in place. And so, trauma-informed care, it's not just therapy. It's an organizational cultural shift. It's how you present. It's how you talk to somebody. It's how you empower somebody to come in and make decisions. It's how you say, hey, you have choice and you have autonomy over your body. You have the opportunity, even if I don't agree with your choices, you have the choice to make. And we have so many women who choose to leave our home. That's their choice. Unfortunately, we're not a lockdown facility. If they want to leave, we will take them to safe drop-off locations. We have those in place. And that is something that we want to empower them in the choices that they make, even if we don't agree with those. And so we really want to talk and do open-ended questions. We really want to give them the opportunity to share with us versus those yes and no questions, and giving them the space to say what is going on. There is a lot of that. We also have to remember, in a trauma-informed care setting and in any setting, what is her reality may not be reality. What is your client's reality may not be reality. May not be what's actually going on, but it is what's going on in their mind and in their world. And so that is something we have to navigate a lot when it comes to trauma. People will make up stories. People will say things to get help because that's the only way that they feel that they will get help. We see that so much in our home. It's just how survivors will make up a story just because that's the only way they felt that they could get the help. And then we have to navigate that when the truth comes out, right? And so just knowing everybody's story and recovery and their process is very different than yours or the next person's. And so we talk about holistic approaches, addressing trauma, addressing triggers, how do we navigate, building those different support groups, talking through those mind, body practices, yoga, being able to navigate and figuring out what works best for that person you are serving. What works best for you? When we think through, our own healing and our own recovery, we have to put things in place for ourselves, and that is something that I will always continue to stand on. And so, what different types of support groups, are you a part of? Do you lead? Do you help others join in? Is case management available? Are you able to offer that case management? We're really big for us. Trauma-informed care is building that trust and finding a way to not break it. Now, that's very tricky in our short period of time that we are with these women, but also we talk, and I say a lot to my staff. I say, don't make any promises because you don't know if you can keep them, one. But two, always, if you do say you're going to do something, make sure you do it. Because if I say, hey, I'm going to take you somewhere tomorrow, and that's my one chance to build a little bit of trust with her, and I don't do it, all trust is broken. And then they've already in recovery and, in addiction and trauma, in trafficking situations, trust has been broken our entire lives. And we have been hurt, abused, manipulated. We have been, whether by choice or not by choice. And so we want to make sure that we are in a space of building that trust. And so I tell my staff, I say, you show up and we go about our day. And what we say, we want to follow through on. And so I stopped saying, when the women would ask me, will I see you tomorrow? And I'll say, my response will be, Lord willing, I'll be here tomorrow. That's my response, because it's not going to say, yes, I am coming tomorrow. But life happens, you have kids, accidents happen. There's so many things that can happen. And so really want to create that safe space to be able to build that rapport with your clients, with those that you are asking to trust you, because the more they trust you, the more they're going to start processing trauma with you. And so just knowing that, choice and voice is huge in this field within trauma, within creating that trauma-informed care aspect. You want to give choice. You want to allow them to have a choice in their recovery, in their next field. And if they don't, then that trust is gonna break, and then they're gonna be like, well, you're just like X, Y, and Z. And that's a hard thing to hear as well. I just have a couple more things. Somebody already mentioned The Body Keep the Score. This book is a really hard read. I have literally started it and stopped it so many times. I have listened to it on Audible. It's a great book though. It really helps you process, like really understand just how the body keeps the score of trauma. And it really helps you understand how trauma affects us. And so it is a great, great book. I highly suggest reading it, looking at it. One of the other curriculums that we use is Seeking Safety. It's trauma-informed care curriculum, and it just really helps empower and build up others. And so I suggest you check that out. Again, I work with the Freedom Collective, and I also work with the Institute for Survivor Care. And so there's just some resources if you guys want to learn a little bit more about those. So that is my presentation for today. I do have one more thing to share with you all, but then we'll open up for some questions for our last 10 minutes. So just to give a little backstory, like I have mentioned, Georgia Council on Substance Abuse has been a huge inspiration in my life. I've been a CARES since 2017, CARES 25, whoop, whoop. And it has inspired me in so many ways. The community, how we build a congregation within this field is just amazing. We need community and we need connection, right? And that is something that I've just held on to. And that's what helps me stay in recovery as well, having community and having connection. A couple years ago, when the peer support specialist of mental health came out, I'm just going to get a little personal here. I am a survivor myself of familial trafficking. And I have experienced trafficking myself and experienced commercial sexual exploitation. And when I was facing prison, and when instead of going to prison, I was able to go to an organization called Out of Darkness. And that is the exact same program called the Freedom Collective now. And so I went through that program almost 11 years ago. And again, we serve survivors of sex trafficking, and it's a passion of mine. And so when the peer support of mental health came out, I was thinking, and I was like, I fully believe that this was a vision from the Lord. I'll just say it. I was like, man, as a survivor, we need something. We need something for us. And so with that, through the Institute for Survivor Care, I presented to them last year this idea. I was like, here's what I have had heavy burdened on my heart. And it is called a peer support of exploitation. And so I presented this to Dr. Jean Allert last year, and she loved the idea. And so we've been working really, really hard this past year This is a national certification, and we have launched just the end of March. We have launched our new peer support of exploitation. Super excited about this opportunity. And so, what this certification does is it's going to ensure that survivors who want to give back in the field, as they become survivor leaders, that they are respected, equipped, and that they are, compensated well for being able to work back, to be able to work in organizations, to be able to give back. And so we have created a structured plan, curriculum for survivor leaders to go through this peer support of exploitation certification. Like I said, we just launched it the end of March, and we launched it small. And so we had a funder come and, who said they would cover the cost for 10 survivor leaders to go through that. And so this first cohort is already spoken for, but we will have our first cohort August 17th through the 21st. It's a 5-day cohort, and it will be in Indiana. But we will have more. And the goal behind this is to continue to grow this certification. It will be a national certification, and to continue to grow it for other survivor leaders who want the extra support, who want the education, who want to work in the hospitals, and who want to be able to go in and say, hey, that girl that just came in, she's a trafficking victim and she needs our help. Versus the hospital's putting stigma. No offense to any medical staff on here. It's just reality of what we have seen. And so this will be led by myself and Dr. Jean Allert. And so I wanted to take the time. I shared this with Al and Dwayne this week, and they were like, Shannon, we want you to share that. And so I just wanted to take the time to share with you guys. This whole training will be grounded in trauma-informed care, how to care for ourselves while serving others. And so again, you will get access to our slides, and you will also have the opportunity. My email is here. You guys, on the slides, you have access to all 3 of my emails: my Institute email, my Freedom Collective email, and my personal email. And so I'm available. So I'm going to take the last 9 minutes, now 8 minutes. I don't want to go over time today, but I want to give you guys the opportunity to ask any questions. All right. Okay.
All right, Nevester Brewer, your hand is up.
How y'all doing?
Hi.
This has been so awesome. But I got a question for you, Miss Shannon.
Yes, ma'am.
You have a program, correct?
Yes.
Okay, I thought I heard that. Okay. Now, my question is, when does it get to the point where you stop putting them out? See, you don't put them out. Sometimes we can put ourselves out.
Mm-hmm.
So when do you get to the point where you say, I'm going to take this girl, love her until she can't be loved no more, and hope that it changes? You know what I'm saying? Because if you know what's going on the outside, it'll hurt the ones that's working on the inside, because we can't stop them. So how do you deal with it?
Oh, well, we have a girl. I will just say we are a yes program. We have, 2 women who come to mind who have been coming in and out of our home since 2013. And as long as they are not disruptive, they are not hurting or harming anybody in the house physically, we typically will say yes. It
Okay.
takes somebody an average of 7 times before they actually leave a situation, whether that's the
Mhm.
addiction, the trafficking situation. And who are we to put a number on that and say, sorry, you can only come here 3 times? And so
Yes.
we are,
Okay.
because we do that emergency crisis stabilization, we average anywhere from 100 to 150 women a year in our safe homes. We have safe homes in now Florida, Atlanta, Georgia, and Columbus, Ohio, and we can average those numbers in each location. That is how severe this issue is. And so we are that yes program. We are not going to put it, because you just don't know when's the next time may be the time. And so we're going to keep giving the opportunity. And there's, when they've come a lot that way, we have to sit down and say, okay, listen, you've been here this many times. What's going to be different? How can we really try and get you over this? I have one resident right now. Well, she's not in our care. She is in her long-term program, and she's one of the ones that's been coming since 2013. And she came back this year, and I'm like, okay, like they say don't have favorites. We all know everybody has a favorite. She might be one of my favorites, right? And she will just come and she'll say, Miss Shannon, I did this again. And I'm like, I know. Okay. So, but this time she's thriving. She's in her program. She's been there, I want to say 6 months now. And she calls me every week, 30-minute phone call. Hey, Miss Shannon. Hey, how you doing? I'm good. How's your kids? They're good. Okay, I love you. And I'm like, well, wait, how are you doing? And she'll say, I'm good. And I say, okay. And she's like, okay, love you, bye. Literally, that's our conversation. She just wants to check in. And it's that consistency that she knows that she can call me and I'm going to answer and I'm going to say, hey, I love you. And I'm going to be there to support even from a distance. And so we don't put a number on them.
Thank you
Right.
so much for that.
The next question is from Bruce Merlin.
Good afternoon. Thank you. And that's great presentation, Shannon. I appreciate it. My statement was about the 75% of women in treatment that experience sexual abuse. In my experience, it is so much higher than that. It's incredible.
Yeah.
And my experience comes from, I'm a co-founder of a nonprofit long-term residential treatment center for women. It's unfortunately not in existence anymore. It was in existence for 14 years, and we're well into the 90%.
Yes.
And being a man in recovery with 36 years clean, working in step workshops with other, men in recovery, it's way up there with men too. And one of the few classes I took, and this was in Orlando, I don't know if I mentioned that, one of the few classes, because I'm not educated, I'm experienced, and one of the few classes I took, and that was one of the things that stuck in my head. According to this person leading the class at Valencia College, he was saying the men's sexual and physical abuse is much higher than the women's. It's just not reported. I just want to say it was really great, and a suggestion, and not to take people's inventory, but this is my first webinar I've done with you all. I'm just getting involved now that I'm retired in my regular career I've had for 40 years.
Yeah.
Wanting to get into peer support, that I think no questions should be asked while somebody is trying to do their presentation. And just me personally, I think it's rude to interrupt somebody. So thanks. Thank you.
Thank you, Bruce, for sharing.
And Angel, is that Angel Johnson? Last name's not in there. You can go ahead and unmute yourself.
Thank you, Shannon, for this presentation. I mean, you opened up a lot of feelings and stuff, that I had stuffed myself. Doing what we do, sometimes, the hardest thing is to kind of remove yourself, out of the equation, especially when people talking about things that hit really close to home. And but I want to thank you because you gave me something when you said how you took the keys off after you left. In the mornings when I leave, in the mornings, I leave everything in the shower. That's my time with God in the morning in the shower, because I'm just like He brought me into the world. So when I in the morning when I talk to God, I tell Him all my worries, all my cares, and give Him my prayers, and then I let Him wash all the worry and stuff into the drain, and then I start my day. And then I have to do that at night, what I'm saying, when I go home, and I take other people's stuff home with me, and I have to say, okay, God, I want to pray for A, B, C, D, sometimes because trauma is very seldomly addressed. When you try to tap into it, it's kind of one of the hardest things to get people to talk about, because, with women sometimes, we wear it on our face. It'd be a little things. For me, it's a gesture or a move like he used to move, or, houses with staircases, because I used to get in the closet and get way to the back of the step. It could be little things that, that draw up that feeling, what I'm saying? So, I try to look out for some of the women, well, all of, not just women, men, because, sometimes we think that trauma is just a woman thing. But I've come to find out that it's an all around thing. But I just really wanted to say thank you for, opening up some stuff that I was really trying to stuff and giving me some other ideas. Maybe I need to do something before I get to the shower at night. You know what I'm saying? Maybe it's because nobody wants nobody to feel that feeling. Once you felt that feeling, it's I don't know. I just want to thank you for being a shero and helping me save the world, girl.
Yeah.
Thank you.
Yeah.
And Angel, I'll say that I always took a shower when I got home from the hospital too, and that was before COVID started. So yes, I know the kind of thing you're talking about. Shannon, it is 1 o'clock on the dot. Thank you
Yes.
so much.
Yes, thank you. And I'll stay for a couple minutes extra, Alvin, if needed. So thank you
Okay.
everybody for this opportunity to present to you today. Again, please feel free to, if you have questions, Alvin will also send out my information, but it is in the slides. So if you have questions, please feel free to reach out and ask.
You'll get her contact information, her slides, that video she mentioned earlier, and whatever else we need to put in when you get your certificate. So just keep an eye out for that. This will also be available on our YouTube page as something that you can rewatch. And I'll have a link for the Georgia Council webinar YouTube page as well, which is a great resource. Shannon, thank you. Hooray. This was really great.
Shannon.
Thank
Great
you.
job.
Thank
Wonderful.
Great job.
Thank
Thank you,
you,
Shannon.
Shannon.